find patient C7, you measure 7 inches inferior, and that will bring you to the patient's T7, the 7th thoracic vertebrae. That is our centering point, vertically. Okay, so our centering point is going to be T7. All right, so come back over here, Shana. So I need to come down about here. I'm going to drop myself down about 1.5 inches.
So we don't have nothing to mark, like a chalk or anything?
So, right now, this tube, it's tough to move it up and down, right? It's kind of stiff. Other rooms, it's much easier to move, so you can actually do this and do this at the same time. You can be moving this while keeping your positioning. Right? But right now, this one is really stiff, so I need both hands to move it. So in this case, I just kind of try and remember around where I was. I adjust, and then I remeasure, just to make sure I'm actually in the correct location. All right. So I see 7 up here, and I just measured down 7 inches to T7. Okay. All right. As close as you can. As close as you can. Very good. So I've gotten my centering vertically, right? Superior, inferior centering. Next, I need to get my left to right centering, right? I need to make sure I'm centered left to right. So, how do I find the midline of the body?
Spine.
Great, I'm going to look for the spine. So this is called the mid-sagittal plane, the MSP. We're going to center to the MSP, which is right where the spine is. So if you feel here, you can kind of feel it dip down, right? And then the spine is going to be right here in the middle. So I should be centered right here. Okay, so in this case, I'm going to slide my patient just a little bit to her right. Perfect. Notice, when I was centering vertically, I move my tube. When I'm centering horizontally, I am moving my patient. Okay? Now, I almost forgot. Ooh, that was dangerous. So, anytime you move your tube up and down, you always make sure to move the bucky as well. In fact, I'm going to go as far as to say is, if you ever move the tube, immediately move your bucky. Drop everything else and move your bucky so that you make sure they stay lined up. So I'm going to press the laser right here. All right, just step a little bit to your left, Shanika. To relax for now. And see, I'm just going to line up my bucky.
You guys can get in. No,
Right
you guys
here.
can get in. Oh, it's called.
So that way I know that these two are lined up, and they're both lined up to T7 as well.
Syndrome.
I'm going to find the MSP one more time, and I'm going to put that MSP and my central ray on top of each other. Okay, so central ray is going through MSP and T7. Make sense? Good so far?
So MSP is mid-sagittal plane?
Correct. The mid-sagittal plane is the line that divides the patient into equal left and right halves. Something to make note of, if you take a look at her feet right now, you notice how they're slightly separated, about shoulder width apart? That is what you want. You do not want your patient to be standing with the feet together, because this is unstable. They tend to move around. Okay, you want the feet slightly separated so that they have a stable foundation to stand on. They're not going to move. Now, after we have gotten our centering, we are going to do the rest of our positioning. So the next thing we need to do is we need to move those shoulder blades out of the way, because the shoulder blades are right here in the middle of the lungs. How do you move those shoulder blades out of the way? Well, if you feel your own shoulder blades, right? When you roll your shoulders forward, those shoulder blades slide out towards the side. So we're going to have the patient bring their shoulders forward to slide those shoulder blades out of the way. Now, there are two ways to do this. The first way is the lazy tech way. So, Shamika, I would like you to reach around this board and grab onto these handles in the back. Great. And now just bring your shoulders forward. Perfect. Lazy tech way. Shoulders are forwards, right? All right, relax, please. Now, what if you want the shoulders to have an even better rotation? In that case, you are going to do chicken wings. Okay, make sure you remember these chicken wings because you are going to use this position many, many times. What you're going to do is you're going to have the patient put the back of the hand down here by the hip. So do not let the patient put their palms like this, right? This is improper. This is not going to give you a lot of motion. It needs to be the back of the hands on the hips. Secondly, the hands should not be all the way up here, right? If the hands are up here, they are going to show up inside the chest. You need to drop the hands down to the hips. So, Shamika, if you put the back of your hand on your hip just like that. Very good. And now bring your elbows forward, bring your shoulders forward. Very good. And that helps to roll those shoulders forward. And so this is the proper way to do your rotation of the shoulders. Does that make sense? Okay. One more thing to watch out for as far as positioning goes, the chin, right? Because it's very easy for the chin to drop down and end up inside the lungs. So you need to lift the chin up slightly. Now, if you look here, there is a chin rest. I do not know why they put a chin rest here, because as you can see, there is no way the patient will stretch their neck all the way up here and put their head here, right? It's not going to happen. So ignore the chin rest. It does not exist. Okay? All you do is you have the patient face straight forwards and just slightly lift the chin. So just like Shamika is doing right now. This is perfectly acceptable. So shoulders are in position, head is in position. Okay, two more things to take care of up here at the board. Number one, collimation. So we're going to take a look at our light field. If you take a look at this light, I'm going to move her hair out of the way. Do you notice that this light here ends basically right where the corner of her neck and her shoulder are? Right? If I open this up, do you notice, right? Neck is here, shoulder is here. Do you see how they form this corner?
Mm-hmm.
And then when we collimated this down, you see how we collimated like right to the corner here? Okay. So this is what you are looking for with your collimation, because the lungs are going to come up here and they're going to stop at the very top here by this rib. They're not going to be able to go past the top of the shoulders. So as long as you're at the top of the shoulders, you know you have all the lungs. Does that make sense? And if you have good centering, that means you should have all the bottom of the lungs as well.
So, Mr. Kung, so
Yes.
you're going to stop like right here, where the shoulder, a little bit above the shoulder.
So you want to stop right here at this corner where the neck and the shoulder meet.
Okay.
Now, Mr. Mako, this happens to be the full extent of our 14 by 17%. Even if I wanted to, I should not open my collimation more than this, right? If I find that this light is too low, what is more likely the problem is that my centering is too low, right? Because if I'm 14 inches this way and I'm missing anatomy, that means I had my center way too low. I need to raise this up. So, speaking of our centering here at T7, is there anything we can use to kind of double check ourselves? Make sure we're actually at T7, than we think we are. Do you notice any other anatomy at about this height? What other anatomy do you see at this height?
Inferior angle of shoulder blades?
Inferior angle. Ooh,
No.
I've not heard that word in a while. No, kidding. Let's heard that last month. This years. So, inferior angle of the scapula. We're not going to learn about that until next semester, I believe. Can we use that as a centering point?
Yes.
Kind of. Honestly, I don't think it's the best. There is something a bit easier to find. You do not need to palpate for this. It's something that you can just look at and see, which makes this a great way to double check yourself. What do you see right here? What is this?
Under.
The axilla, the armpit. T7 is at about the level of the armpit. So, if you think you're a T7, just draw a line across to where the armpit is and ask yourself, does that look like I'm at the axilla? Does that look like I'm at the armpit? If it is, then yes, you're probably at T7. If it looks too high or too low, then you might want to double check your centering. Like the armpit's not always going to be T7, but the armpit is a great way to kind of check yourself to make sure you're not too far off. So, shoulders forward. I do look like I'm centered at T7. I do have my collimation here. Right, one more thing, when you do roll the shoulders forward, try not to have them hunch the shoulders at the same time, right? You want them to roll the shoulders while staying relatively relaxed. Right, so try and relax the shoulders while rolling them forwards. Right, I know it's tough, but that is what we want our patients to try and do. Right, so do not raise the shoulders when you roll them
So
forward.
the instruction is bring your shoulder forward.
Right, straight forwards without bringing them up. Okay, so our collimation is pretty good. We want to check our vertical collimation, check our horizontal collimation, make sure we have all of the patient. And now we need to add something to this image. What are we missing?
Markers.
Markers, very good. So I have a left marker, I have a right marker. Which one do you want me to use?
Right.
Right.
All right, right marker, sure. Okay, I've got a right marker. Where do I want to put this? On the side close to me or on the side farther from me?
That one.
Farther.
Farther.
This side?
Mm-hmm.
This is the right side?
That's her right side.
Good, this is the right side. And then, what projection is she in?
Posterior. PA.
Yes, posterior, anterior, PA. So my marker will also be placed in a PA projection. So this is the front of my marker, right? This is where the color is. Right? This is the back of my marker. It's white. So I'm going to put my marker, PA, right? Back, posterior, anterior. And I'm going to put it right here in the corner of the light field. Okay? So my marker is matching my patient. So everything should be set up now. I am ready to shoot my X-ray, correct? Now, because we are doing the chest, because we are looking at the lungs, we do have specific breathing instructions. We want the lungs to be nice and full of air when we shoot the X-ray. So what should the patient do first before we shoot the X-ray?
Breathe in.
Breathe in.
Big breath.
Great. We want the patient to have done inspiration, right? Breathing in. We want to expose on inspiration. However, the first deep breath that a patient takes in will not expand the lung to its full capacity. We actually need to do 2 breaths. So our instructions will be, take a deep breath in, blow it all the way out. Take another deep breath in and hold your breath. Hold your breath. X-ray, and then you can breathe, you can relax, breathe normally. Right, so 2 breaths. In, out, in. On the second one, that is when the patient holds their breath and you can shoot with X-ray. Does that make sense? All right. Make sure when you are giving breathing instructions that you are watching your patient. Do not rush your breathing instructions. Right, so you don't want to be like, all right, Shamika, take a deep breath in, breathe out, breathe in again, and hold your breath. Right? You're not going to give time. The patient won't have time to follow instructions that way. They won't breathe properly that way. Right? So watch your patient. Okay, take a deep breath in. You can see the shoulders rise, right? Breathe out. You can see it fall. Take a deep breath again. Hold your breath. X-ray. Breathe and relax. Right? So watch your patient when they breathe. Right. One more note about breathing instructions. A lot of times, what happens is you set up the patient, you walk back here to shoot your X-ray. Like, all right, Shamika. What did my patient just do? Turn around, right? I was about to give breathing instructions, but they turned around, and now I need to set up the X-ray all over again. Just can't follow this. Right? That was a great demonstration. Thank you. So, what should you do? You should probably give your patient warning ahead of time. So what I like to do when I'm working with the patient is, right, I'm doing my T7, right? I'm doing the shoulders. I'm doing my centering, right? I don't have very much to talk about during this time, other than, okay, just roll your shoulders forward. So what can I do instead? While I'm doing all of this, I'm going to be telling my patient about the breathing instructions. So, all right, so Ms. Shamika, in just a moment, what I'm going to be asking you to do is take in 2 breaths, okay? So I'm going to be having you take in 1 breath, blow it out, take in a 2nd breath, and then I'll have you hold your breath, okay? And it's important that you try and hold as still as possible, right? Don't turn to face me, okay? So I'm making use of my time while I'm positioning to also give the patient instructions, so that by the time I'm ready for my X-ray, my patient is already prepared mentally for what's happening next. Right, I'm about to step behind a wall, and I'm going to be giving you some breathing instructions. Once again, just make sure you stay still, keep facing forwards. All right, Jamaica, take a deep breath in, blow it out. Take another deep breath in, hold your breath, X-ray. You can breathe, you can relax. Right? Very good. We can actually relax now. Thank you. Let me take this off here. Right. So, any questions about the PA chest X-ray? All right. Good job. So, who would like to be our next patient? Hey, Veronica. So, our next X-ray is going to be the lateral chest X-ray. Okay, I'm going to start with you facing the board. So I'm going to pretend that we just finished a PA chest, right? So get up nice and close. I'm just going to estimate our centering. Careful, careful, careful. All right, so something like that, right? Okay, we just finished our PA, and now we're going to turn our patient to the lateral. All right. For lateral chest X-rays, we always do them with the patient's left side touching the IR. So turn your whole body to face me, please. And relax your arms, just whole body facing me. Okay. From here, we are going to have the patient lift their arms up above their head. Okay? Personally, I like to stand here and demonstrate what I want the patient to do. Hands above their head. Very good. Okay. Notice that we want these arms up. The reason is because if they were down, so bring this down, bring this down, bring this down. If it's down like this, the soft tissue here, right, the muscle, the fat, any soft tissue here is going to end up inside the lung. We want to raise this arm up as much as possible to keep the lung nice and clear on the image. Does that make sense? So we're going to have the arms up. second thing we're going to do is we're going to try and get the patient's shoulder as close to the board as possible. So I'm going to have you take a small step to your left. Great. And what I'm going to do is have you take your left foot and step over just a little bit more. Very good. So by doing this, patient's feet are about shoulder width apart, right? So nice steady foundation. And their shoulders and hips are nice and close to the IR. However, what you should not do is you should not try and reduce OID so much that you ruin your position. So right now the patient is nice and straight, correct? But if you look here, what do you notice?
Yeah.
You notice a gap. So, okay, Veronica, I'm gonna put your side all the way up against the board. Get rid of the gap. That's right. No more gap, right? Gap is gone. But what do you notice about her body?
Leaning.
Right, she's leaning like this now, right? That is not good. You want your patient standing nice and straight. You don't want them to lean. So bring your hips up over. Nice and straight. As close as you can but without leaning your body. Feet apart, left leg over. Yep, perfect. Okay. So body nice and straight. A bit of gap, but that's okay. So never compromise your positioning to reduce OID. Okay? Reducing OID is good, but you should never destroy your position in order to reduce your OID. Positioning always takes priority over OID. If you need a little bit of OID to get perfect positioning, take that little bit of OID. Okay? It's better to have perfect positioning and OID than improper positioning and no OID. Right? OID is not the important thing here. Positioning is the most important. Now, step over towards your right. If you had this much OID, then okay, yes, I'm taking points off because you could reduce this while having perfect positioning, right? The thing is trying to go from perfect positioning to imperfect positioning in order to reduce your OID. And so don't do that. All right, so okay, get nice and close again. All right. So second thing to worry about on your lateral chest X-ray. This is a lateral chest X-ray. The patient should be sideways. So you need to make sure your patient is actually sideways. How do you do that? You're going to check the patient in 3 locations. Shoulders, mid-back, and hips. So I'm going to be checking your back to make sure you're nice and straight, okay? So once again, telling the patient what you do before you start touching them. I'm going to check up here at the shoulder. Right? I want to make sure that the shoulder doesn't feel twisted one way or the other. I want to make sure that this shoulder feels nice and straight, perpendicular into the board. The shoulders feel good, I'm going to move down to the mid-back. The mid-back feels good, I'm going to move down to the hips. I want to make sure all 3 points feel good. You can relax, Veronica. So, why is that important? All right. So, let me stand here. So imagine that I'm the patient and I'm standing here, right? All right, so come check my shoulders and come check my back. Just put your hands so that you can feel both my left and right shoulders. All right, you can feel both my left and right shoulders together, right? All right, and then come down here to the back. Right, and it feels the same, right?
Yes.
Okay, now, watch what happens. Let's say that your patient was standing like this instead. All right, check my shoulders. Does that feel straight?
No. It's uneven.
It should.
It's like this. That's straight.
All right, and now check my back.
It's
My
uneven.
hips. Right, so the shoulders can be straight, but the hips can be uneven. Right? And vice versa, right? The hips could be perfect, right? But then, right, so check my hips here.
This is straight.
Okay, and then check my shoulders.
Go straight.
I shouldn't be, because I'm halfway turned to Jamaica, right? So my shoulders will be crooked, but my hips will be straight. So it's important that the entire body is truly sideways, right? No part of the body is twisted off to the side. So that's why you check the top, that's why you check the bottom. So very common mistake is that the feet here are not next to each other in line, right? Like in front or behind, we'll twist the hips. Always make sure those feet are lined up. Okay. And then arms straight up. Right. Veronica, just step back here, please. Okay. Go nice and close, nice and close. Small step forward.
It's hard, yeah.
Like, laterals are difficult. These are difficult to try and get perfectly straight. All right, so now let's say that we have proper positioning. We also want to have proper centering. Now, on the PA chest, where did we center?
T7.
T7. On a lateral chest, where do we center?
T7.
Still T7. So should I change my centering between my PA and the lateral?
No.
I do not need to. Now, some texts will tell you that you should drop your centering about 1 inch when you go to the lateral. This is probably more true on male patients or thicker patients because you will get more divergence of the beam. But on a small patient, we can leave it at exactly the same height. So either leave it exactly where it is, or on a larger or on a male patient, take this and drop it down about 1 inch. Okay. Does that make sense? In this case, I'm going to leave it right here where the PA was. Okay. So, on the PA, when I try to center left to right, I use my MSP, correct?
Mhm.
Mid-sagittal plane. On my lateral, I'm not trying to center anterior, posterior. How do I get my centering? Do I still use the MSP?
MSP for the thorax.
So what is this called?
Horizontal?
This is your mid-coronal plane.
Yeah,
Your
yeah.
MCP.
Anterior and posterior.
So MCP divides the body into anterior and posterior halves. So MCP is going to be right about here. Right? If you're not sure, you can always try to pat down your patient's clothes to try and find the middle here. But of course, just be careful, especially on female patients. You don't want to pat too high, right? So for me, sometimes maybe I'll just tug the clothes here to get it closer to the skin. That way I can see it without the bagginess giving me like a false sense of where the shadow falls. So, Veronica, I'm going to have you slide forward just a tiny bit. Very good. So there we go. This is about where I said my MCP would be. If we take a look at how much light is in front of her stomach here. Do you see that small sliver of light? Now, come back here and look at how much light is behind her. Do you see the small sliver of light? Notice how the sizes of that light are about the same? Right? That's how you know that you're in the middle, right? You should have the same amount of light, the same amount of shadow on both sides. So, patient is in a true lateral, and now I am centered to T7 and the MCP. Okay, arms are up. I have minimum OID. One more thing to watch out for as far as positioning goes, the chin. Very easy for the chin to dip down into your x-ray. Always dip the head up slightly. Doesn't need to be anything crazy, right? But just make sure the chin is up slightly so it does not show up in the picture. All right, so that is what we need to do as far as positioning goes. I just realized I forgot something.
Marker.
I forgot your
Yeah,
shield.
Marker.
So marker was next, but shield should have always come first. So Veronica, if you would mind, put this on me. Great. One more thing to make note of. With this shield, sometimes the shield, you can kind of adjust it to where one side is higher than the other. If you are able to do that, you want the front side higher, you want the back side lower. And the reason is because the lung is lower in the back than it is in the front. All right, great. So we have our patient shielded now. Now we're going to do our collimation and our marker. So for collimation, you don't want to collimate vertically because you want the entire lung up and down. Usually your collimation is going to be horizontal. Right? You're only going to collimate enough to the soft tissue edges, right? You don't want to clip off any anatomy in the chest. Now, are you allowed, do you need all the breast tissue in your chest x-ray? You do not. So it is okay to cut off the breasts. The breasts do not need to show up on the x-ray, as long as the front of the chest and the back of the chest show up on the x-ray. Finally, we have our marker. Which marker are we going to use?
Left.
Why the left marker?
Because that's closest to the board.
Good. Marker is going to be the side closest to the IR. Just a little bit just a second. There you go. All right. Right there. Okay. Stay nice and straight. Nice and straight. Good. So left marker, I'm going to put right here because the left side is closest to the IR. That's right. It is face up now. It is AP. Right? You're not going to take the marker and put it lateral to match the patient. Can't read it that way. So you're going to have it AP. All right, great. And now we need to do our breathing instructions. Are they going to be the same as the PA?
Yes.
Yes. So, Veronica, take a deep breath in, blow it out. Another deep breath in, hold your breath. X-ray, you can breathe, you can relax, bring your arms down. Notice that as we went on, her arms got lower and lower and lower and lower, right? It's hard to hold the arms up that long. So, you do want to be able to learn to do these quickly so that your patient doesn't get tired. Now, we do have this tool right here.
Probably just like that would have helped.
So, for example, our patient can hold on here.
Oh.
But,
Yeah.
what do you notice is the problem?
The arms.
Arms, right. Are you able to reach the top one?
Oh, okay.
Okay, so maybe she could reach the top one instead. Keeps the arms up out of the way. And that way, her arms are less likely to fall down. So, if you have this, this is a tool you can make use of. Okay, thank you, Veronica. You can relax. And I'll take the shield off.
You did good.
It is hard to hold these positions for a long time. So it is important that you learn to be more than just competent. It's important to learn to be skilled at these positions so you can get through them quickly so you don't tire your patient out. Especially because if you work with like older patients, they're not going to be able to stay still for very long. All right, great job. Any questions about the lateral?
I don't have it for the lateral, but PA
Yes.
chest, the marker always had to be in the right side.
No. So that's a great question. We used the right marker on the PA, correct? However, we went to the lateral and then we used our left marker. For me, I feel like it's a waste of energy switching from right marker to left marker. So I use left marker for all my chest x-rays. I put the left marker here on the PA, I put the left marker here on the lateral. Right? That way I only need to use a single marker for the entire exam. And the thing is, you need to make sure that you are putting it on the left side, and then you put it on the front of the patient, anterior side of the patient, when you do the lateral x-ray. Okay? You should not have it posterior to the patient on your lateral, anterior. So yes, I do recommend using the left marker for all these. Right. Any other questions? In that case, can I get a third volunteer? Sindhu, okay, great. So for this one, we are doing the AP chest x-ray. So stand back against the board. Oh, stand nice and straight, back against the board. So we are AP, facing our tube. Sorry. Okay. Now, the positioning for the AP is going to be very similar to the PA, by the way, let's go ahead and put this on before I forget. This is a force. Yep, let me help you with that. Good. All right, good job. So we're still centering at T7. We're centering MSP. We're going to be collimating so the light is right above the shoulder. We're going to roll our shoulders forward. We're going to have the same breathing instructions. Okay. So AP and PA are very, very similar. However, AP does have a small twist to it. On the PA, how did we find our centering? So on the PA, how did we find it?
Oh, PA, yeah.
Mid-sagittal.
T7.
Great, we found T7 in mid-sagittal plate. How did we find T7?
C7 was.
Great, we found C7 and we measured down, right?
Yes.
Can you do that on the AP?
No.
No. So, how do you find T7 on the AP? Okay, so one thing you can do is jugular notch. You find the jugular notch, you measure 3 to 4 inches down, and that is going to be your T7. Now, on myself, you would be fine to palpate for jugular notch and measure down. On Sindhu, I don't think I would be allowed to do that, right? So once again, we need an alternative method, right? Because you can't just go, for female patients, it's going to be very difficult to measure or to palpate off the jugular notch. So earlier, we mentioned that there's a certain anatomy at the same level of C7. The axillary, axilla, armpits right here, right? This is something that you can visually see. If you need to palpate, you can do so without touching any sensitive areas, right? So this is a lot easier to center off of. Something else you can use is an imaginary nipple line, right? Only problem with imaginary nipple lines is if you have a female with sagging breasts or a guy with like a sagging chest, that imaginary nipple line is going to be a lot lower than you expect. So rather than using that, I do prefer to use the axilla. Okay, so stand nice and straight, relax your arms, right? Because you're a normal patient, you don't know anything about chicken wings, right? So you're just going to be a normal patient, and first thing I'm going to do is I'm going to try and find that axilla. Okay, so axilla looks like it's going to be right about here. So I'm just going to drop this down a tiny bit more to that axilla. All right, lift the arm up slightly. Good. Yeah. Oh, I think I went down a bit too far. Okay, great, you can relax. So I am here at the axilla, I'm here at the armpit. Okay. So, anytime I move the tube, what do I need to move?
Bucky.
Bucky, very good. So I turn on my laser. We're going to feel this board slide down behind you. Warn my patient about what's going to happen. Don't want the board to slide behind them and they suddenly jump up and freak out. But I've seen that happen before. All right. We're now centered vertically. We need to center horizontally, left to right. Which plane are we using? Is it MSP or MCP?
MSP.
MSP, good, straight down the middle. Right, so remember, once again, anytime I go left to right, I'm not moving the tube, I'm moving the patient. Right, so just slide towards me a little bit. Very good. Right, so I'm taking a look here, right? I'm using her neck to check the center. Right, if I want to, I could try and palpate for the jugular notch now, right in the middle, just to make sure I'm going through the center of that jugular notch as well. So now I feel like I'm pretty well centered. Let's keep positioning. What do we need to do with the arms? Great. All right, so if you would take the back of your hands and put them down here on your hips. Very good. And now, which way do the shoulders go?
Back, forward.
Forwards. Always forwards. Right, so we're going to have to roll the shoulders forwards. Okay, this time it's going away from the board. All right, great. So I can see the shoulders coming forwards. Excellent. Something that can help, right, is also asking them to bring their elbows forward. Right? You see, when you bring the elbows forward, the shoulders will follow. Okay. Chin, ask them to just lift it up very slightly. She's already done that for us. Very good. And now we are going to collimate. So we take a look at our light here. Oh, sorry, let's get you back into the middle first. Good. Okay, so let's see, 14 by 17 right here. Okay, so this is what we're starting with. Okay, and now we're going to collimate in. So I have a lot of light above the shoulders. So I'm going to drop that down, right, to that corner that we were talking about. Over here, let's see. So I feel like I am slightly off center down here at the hips, right? I look centered at the top, but not at the bottom. So I think what's happening is she's kind of leaning like this. So Cindy, what I want you to do is with your left foot, step over, please. Very good. All right, see how that looks more centered now? And now top and bottom are centered. All right, great. So I've collimated. This is my light field now. I need to place my marker somewhere in this light field. I'm going to be using my left marker. And where am I going to put this left marker?
Close up to the
Patient's left side?
yeah, right here.
Patient's left side, very good. It's very tempting to put it on your own left side, but right now my left is the patient's right. So always right, stand like your patient, think to yourself, all right, this is left, and then place the left marker right there. Okay. Now, what is the final thing we need to do?
Breathing.
Breathing. Good. So, Veronica, could you try giving us breathing instructions, please?
Cindy, I'm going to have you do 2 breaths in. You're going to do the breath in first one time, and then you'll breathe out, and then the second time you'll hold it, okay? So breathe in, breathe out, breathe in, hold it. You can breathe normally now.
Very good.
Good job.
And do not forget to tell the patient they can breathe normally. You will have patients that will try their very best to keep holding their breath even after the x-ray because you forgot to tell them to breathe and then they pass out on the floor. Okay, so always make sure you tell them at the end, you can breathe, you can relax. All right, great job. All right. Are we done? What do you mean are we done? Done with what?
Still have,
Done with the,
still have
done
like
with the AP, yes.
7
You're done with that
positions.
AP.
Yeah.
All right, so who was, are you Samantha?
Is any, are you sure? Okay. All right.
Okay, come on over. Back against the board, please. Actually, no, I'm sorry, you can relax for now. You can relax for now. We do have something to talk about first. So, our next projection is called the AP lordotic chest. Does anyone know what the term lordotic means?
At an angle.
Angle? Okay. That's in the right direction. Very good. What about lordosis? Or kyphosis?
Messed up spine. I don't know.
Or
if it's curved curvature.
scoliosis?
Yeah, that's a curved spine. Yeah.
Yeah, so we've all heard of scoliosis, right? Curved spine. Right, so scoliosis happens when the spine curves almost like an S shape, right? Side to side. Right, so it comes off like that. And so scoliosis is spine going in this direction. But we also have kyphosis, which is the spine going like this. And we have lordosis, which is the spine going like that. So on our AP lordotic chest, we are going to make the patient curve their spine backwards like this. Right? So, okay, Samantha, I'm going to have you put your back against the board. So, step 1 is that we are going to start off exactly like our AP. So, I'm going to put this at the level of the axilla. Pardon me, I'm just lift the arm just a little bit so I can check right here. All right, great, you can relax. Looks like we're in a good spot. Looks like we're in a good spot. Okay, so this is how we would be set up for our AP chest X-ray. From here, what we're going to have our patient do is we're going to try and move them about 1 foot in front of the board. Okay, so we're going to try and get them 12 inches away from the board. So I'm going to step forward to about right here. Good. And then we are going to have the patient lean back into the board. So I'm going to help support you.
Okay, it feels a little weird. Like,
It's okay. It's okay.
space. Okay, it's not that far.
Not that far.
It's not me.
There's a lean back, lean back, lean back.
Okay, all right.
All right, very good. And you see how her back is curved, right? All right, very good. You can stand up again. All right. So that is one way you can get that lordotic position. However, what did you notice that Samantha did?
She stepped back.
Right, she was uncomfortable. She was scared. It feels like one of those crazy team building exercises, right? Where you like fall back and you hope the other person will catch you, right? So that's not a great feeling to have as a patient, correct?
Right.
So here is the second method. All the way back against the board, please. What I'm going to have you do is you're going to keep your back against the board and just now you shuffle your feet forwards. Right above you. Great. And after she shuffles your feet forwards, from here I want you to puff out your hips, puff out your chest. Good. Bring them forwards. Puff, puff, puff. Great. You see how we've got that curve again? But now it was a lot more comfortable for the patient because they were in control the entire time. Okay, you can relax. Thank you, Samantha. All right. So you kind of see how that lordotic position works. You can do it both ways, but I do prefer letting the patient stay in control. All right, let's try again. So just shuffle forwards a little bit. Okay, curve, great. Now, I was centered to her T7 earlier, right? Am I still centered to T7? Right? This is not T7 anymore. T7 is down here. I need to drop everything. But she's leaning against my board. I really don't want to drop it at long distance while she's leaning against it. Okay, so stand up, please. Stand up and relax. So here is the trick. All the way back against the board. All the way back, all the way back. Stay nice and straight, nice and straight. This is our starting AP position. Right? In fact, I'm going to go ahead and collimate that as well. What we're going to do is we're going to take the light, which is currently at the corner of our shoulder, right? So you see, we're at the corner of the shoulder. We're at the corner of the shoulder right here. We're going to take this light and we're going to drop it down to this corner of the shoulder instead. So we're going to drop this down about 2 to 3 inches. Right. And now I'm going to do the same thing over here at the button. So this person's going to slide down behind you. Try to relax. It's going to slide down behind you. Great. So I've now dropped everything down about 3 inches. Right, now Samantha, lean back. Right, only to shuffle forwards. Right about here. Yep, very good. And now only puff out your hips, puff out your chest. Very centered. Right here at the axilla, where's our light? Right here above the shoulders. We end up with perfect centering. You see that? So start in your AP, drop everything down first, 2 to 3 inches, and then have your patient go into the lordotic position. And now I don't need to move anything. So this way the patient will be able to stay comfortable. All right, Samantha, what I do want you to do is just spread out your feet a little bit more so that you have a bit more of a foundation, right? It feels more stable for you. And now we're going to do the same things we did with the AP chest X-ray. So I'm going to make sure that we are MSP, right? Look down the neck, look down the body, make sure everything looks the same on both sides. We're going to do arms, chicken wings. Okay, so back the hands on the hips and roll the shoulders forward still. Yep, so that's right, elbows forward, elbows forward. Good. We're going to lift that chin up because we don't want that in our X-ray. Great. We're going to collimate a little bit more. We're going to put our marker right here. We're going to give breathing instructions. Take a deep breath in, blow it out. Deep breath in and lift your chin up. X-ray. You can breathe out and relax. All right. And that is our AP lordotic chest X-ray. Right. And of course, in the interest
Thanks.
of time, I didn't do it, but make sure you shield your patient as well. Always shield your patient. So, any questions about that one? I know that one looks kind of crazy.
So why if the lumbar portion of their spine is off, so why do you have
So why are we doing this, right? So the reason we do this, when we do a normal chest X-ray, the lungs come all the way up here to the top of the shoulders, right? Right here, there's something in the way. What is this? Great, it's the clavicle, the collarbone, right? This shows up at the very top of the lungs, the apices of the lungs. Sometimes we need to see the apices of the lungs clear of superposition. We don't want any bones in the way. So when we lordotic our patient, we're taking these clavicles and throwing them up above the lungs. We're shooting under the clavicles so that we can see the top of the lungs without anything over them. So that's the purpose of this projection. So for example, for something like secondary TB, lordotic position would be able to help with that. All right, any other questions? Okay, good so far? All right, let's keep going. Okay, I guess I'll need another, well, try to repeat, I guess. Who did we have? Veronica? Or Shamika? I don't remember who was first. Okay. Okay, so next up, we are going to do obliques. So obliques are going to be a position halfway between your lateral and either an AP or a PA. Right? So actually, let me flip over here for just a moment. Right? So if I'm lateral here, right, and I turn this way, right, AP oblique. I turn this way, right, PA oblique. So the projection, and remember, projection is the path of the X-ray beam. The projection is either AP, enters through the front, like anterior, exits the back, posterior, or the projection is PA, enters posterior, exits anterior. However, we also have positions. Have you learned the difference between projections and positions? Not yet? Okay. So projections are going to be the path of the X-ray beam. Positions is how the body is actually placed. Right? So this is often in relation to the IR. For example, what is this projection?
Oblique.
Yes, anterior, posterior, oblique. It is an AP oblique. However, that is only the projection. My position is going to be what is touching the IR. So left side and posterior side. So left posterior oblique, LPO, very good. What about if I was this way?
RPO.
RPO, right side and my posterior side are touching, right? So right posterior oblique. What if I was this way?
Left anterior oblique. Left
L-
LAO.
Good, left anterior oblique. Left side and anterior side are closest to the IR. Okay, what about this way? Good. Right side, anterior side are closest to the IR. REO, right anterior oblique. So those are positions. Okay? So the projection here is AP oblique, but the position is LPO. Right? They're both describing the same thing. It's just, they're both describing me, the patient, standing in the same way. It's just one is dealing with the path of the beam, one is dealing with how I'm standing with the IR. Does that make sense? Okay. So you may hear me use both of these terms. Don't let that confuse you. All right. So, Veronica, we'll step over here. And we will start.
We're shooting.
Keeping me from being a bad tech. I appreciate that. And even putting on the show yourself. I wish all patients could do that. Okay. So for obliques, personally, I like to start off in either the AP or the PA position. So let's start off AP, back against the fourth, please. All right. And I'm just going to get myself lined up once again to T7. Right, so that looks like axilla to me. I'm going to raise this up. All right, great. Let's go ahead and make this our 14 by 17. All right. So here we are, 14 by 17 lengthwise, AP chest. Now I want to go from here to an oblique. With the oblique chest, you're going to turn the patient 45 degrees. So this is halfway between AP and lateral. So I want you to turn your whole body to face me, please. So with us, point your toes towards me. Very good. Okay, and bring this left foot forward just a tiny bit more. Good. So I'm trying to get her whole body in a 45-degree position. That means feet need to be 45, hips need to be 45, shoulders need to be 45. Okay, the whole body is 45 degrees. Remember, 45 degrees would be like going from corner to corner on this tile, right? That is 45 degrees. And that's what I want my patients to be doing. So, notice that I'm leaving this I am leaving this at a 72-inch SID, right? Chests are done at a 72-inch SID. Great, so I've got my patient 45 degrees now. How can I double check? I'm going to come back here and I'm going to check the shoulders. I'm going to check the back. I'm going to check the hips. Make sure all of this goes 45. Make sure the feet look 45. Right? That is how I know I am in a good oblique. If my patient was like this, over oblique. If my patient was like this, under oblique. Right? So I want to make sure I have that true 45-degree oblique. Very good. And I'm going to have to step towards that wall just a little bit. Let's step back to the board as well. Very good. Feet are still 45. Very good. Okay. So we have our rotation. Rotation is very important. Everything depends on your rotation. You cannot get good centering if you do not have good rotation. All right, from here, we are going to need to move the arms. So, what we're going to do, in the case of the AP oblique, and we don't need the light. It's okay. Like I said, light makes us feel comfortable, light makes us feel like we can see what's going on. But right now, we don't really need the light. So all we're doing is we're going to position the arms. For the AP oblique, the arm closest to the IR is going to go up. The arm farthest from the IR is going to go down. Right? So my old teacher used to call this the sassy position, because it looks like I'm about to sass you, right? So, very good. So closed arm goes up, far arm goes down on the hip. Okay, notice that our patient is also taking this arm that's up and bringing it like this. Why? Because that reduces OID. Right? If the elbow is sticking out, it would push the patient away from the IR. Right? So you want to bring this arm in so they can get as close as possible. So, very good. With your left foot, can you step out towards my foot just a little bit more? Very good. And once again, make sure that you're standing nice and stable. Feet above shoulder width apart and nice and close to the board so you're minimizing your OID. All right, make sure our patient is standing straight. It looks like a little bit crooked. I think we can actually come closer to the board with your feet. Good. There we go. Much better. So arms are in position, patient is rotated. Now we can find our centering. Height, superior, inferior. Where do you think we center?
What is it? T7.
T7, very good. Hold on, I'm sorry, V2. Network's getting dry. So we're going to center T7. I started with the patient AP at T7 already, right? So do I need to adjust the height at all? No, I'm already good. So all you really need to worry about is centering this way, correct? Now, on the PA or the AP, how did I center in this direction horizontally?
Moving, yeah.
I moved the patient, and what did I use to figure out my centering?
Oh, MSP. Oh,
Right, mid-sagittal plane for the AP, right? On the lateral, what did I use to find my centering?
MCP.
Great, my mid-coronal plane. So right now I am halfway between AP and lateral. So where do you think my centering is going to be? Halfway between.
Transverse or axial?
Halfway between the MSP and the
Oblique, no.
MCP. Good.
Okay.
So because I'm halfway between AP and lateral, I'm centering halfway between their points. I'm centering halfway between the MSP, halfway between the MCP. Does that make sense? So if I know her MSP is here, and I know her MCP is here, I can find MSP, I can find MCP, and I can go right in between. So this is MSP, and this is MCP. I'm going to be right here in between. Does that make sense? So let's see how close or how far we are. So MSP, MCP, actually I want to be right about here. Pretty close. Just slide back a tiny bit. There you go. Oop, too far. Okay, bring your hips back. Just the shoulders back. So when I slide her like this, I do want to make sure I'm not accidentally rotating her. Right? So instead of trying to say, okay, I need to be here, so I'm going to turn my patient. I don't want to turn my patient. I'm going to take the patient and move them as a whole, right? Slide your whole body forwards or backwards like this. Does that make sense? Try not to turn your patient to get to adjust your center. So MSP, MCP. So slide back a little. There you go. Perfect. Okay. And now we are in between our MSP and our MCP. And you take a look. You can see some light here on the board, right? You look back here. You can also see some light on the board. Right here. It should be about even on both sides. So it should look like here. And then you want the light here as well. And now we collimate and we mark. So collimation, I can see a lot of light above the shoulders, so go ahead and collimate that off. Chin, have you raise your chin just like on all the previous ones. Okay, marker, which marker are we going to use?
Left.
Why left marker? Good, left side is closer to the board, so I am using my left marker. See some light up here? Okay, so great, I'll just squeeze it in this corner right here. If I didn't have light there, I could squeeze it down here like that, right? No problem. As long as I don't take this and stick it inside the shadow there, I'm going to be safe. I do this, and now I have an L inside the lungs. You don't need to mark the lungs with L. Doctors already know that they're lungs. So make sure this stays outside. Finally, breathing instructions. Sindhu, could you give us breathing instructions, please?
We're on.
Can you take, I'm gonna give you breathing instructions. So I'm gonna do two, breathing. So take a deep breath and, how do you say, breathe it out. One more deep breath and exhale and relax.
Good. Now, for the second one, don't forget to tell them to hold your breath. Second one
Hold
is
your breath.
deep breath, hold your breath, X-ray, and then relax. Very good. Great. Thank you, Veronica.
So one, I'm
Arms are
sorry.
okay?
Yeah, the position she was in anterior left obliques, right?
So she was standing like this.
Uh-huh.
So what is closer to the board, the front anterior or the posterior?
Posterior.
Posterior. What-
Posterior, left oblique,
Other way, left posterior.
left posterior,
Very good. LPO.
LPO. Yes.
So that was an AP oblique projection. Right. Shamika, come on over. This time we're going to try the opposite. We're going to do a PA oblique projection. So come over here, please. Stand facing the board. Get nice and close, nice and close. Very good. Let me double check your C7, T7. I want to be right about here. All right. Yep, that's not going to happen. Yes, thank you for reminding me. Making me look like I'm being a bad tech today. All right. Step over here to the side, Shamika. All right, let's see. I'm going to give you this. Just bring it all the way around your body. Oh, sorry, I went the wrong way. Okay, bring this all the way around your body. Here we go. Okay. All right. Go ahead and step over to your left side, please. While I raise this up. Great. So this time, let's try doing, do you guys want to see an LAO or RAO?
Let's do R.
RAO, okay. So I'm going to take my patient, I'm going to turn them so the right side is closer to the board, right? Once again, we're going to make sure this is a 45-degree oblique. All right, so feet actually look really good already, so I'm not going to adjust that. I'm just going to check her body, shoulders, back, hips. Very good. I think she is in a 45-degree oblique. So now we need to do positioning. As far as the arm positioning goes, okay. As far as the arm positioning goes, what are we going to do? We are going to have sassy, yes, but this time it's the opposite. Remember, last time I said that close side goes up, far side goes down, right? Now it is far side that goes up, close side that goes down. So, you go with your hands like this, far side up, close side down. Right? So far side up, close side down. Now, something else you can do while you're in this position. Instead of the hand going on the head, you can put the hand on the IR instead. So they can grab onto the IR.
And my arms go straight out like this. or-
Yep, keep it up straight. So you can go either way. Either way is fine, whatever you feel is more comfortable for the patient. Okay, while you're here, I'm going to try and adjust the shield. So then let me slide this around just a tiny bit. There we go. So we're trying to keep this in between the patient and the tube. Once again, just like on the AP oblique, our centering is midway between MSP and MCP. So I'm going to find the MSP, I'm going to find the MCP, all come together. So I'm going to center right about here. Oh, pretty close. All right, So I'm just going to slide you over this way. Very good. All right. If you take a look at her right now, so MSP and CP. Oops, sorry, just tiny bit more. And take a look at the shadow here on the body, right? See shadow here, and you see shadow here. Shadow should be the same on both sides. The amount of light should be the same on both sides. In this case, because the body does look like this is going to need a crosswise collimation, let me try and switch it over to Dutch. See if we can get all the way out to the edges of the body. All right, see, now we're a lot closer to the body. So this way I feel more confident we are not going to miss anything on the switch way. Good. All right, so both sides, MSP and CP right in between. Good so far? Shamika, go ahead and lift your chin up. Make sure that chin is out of your x-ray. And now we're going to double check our collimation. Collimation looks fine, doesn't look like there's anywhere I can come in. Which means it's time for my markers. Which marker do you think I should use?
Right?
Why right marker?
Her right side is touching.
Yes, her right side is touching. So I see a little bit of light here on the right side. That's where I'm going to squeeze this marker. Notice that my marker now is PA because my patient is in a PA oblique. Make sense? Okay. So Samantha, could you give us the breathing instructions, please?
Sure. Okay, Shamika, I'm going to have you breathe in twice on my count. Go ahead and take a deep breath in. Let it out. Breathe in again and hold it. Okay. Okay, and go ahead and you could breathe.
All right, very good. So that is our PA oblique chest. You can relax. Thank you, Shamika. Any questions?
I think it's my turn next.
Any questions?
Thank you.
Does he help?
Yeah, I'm trying to see where it's at. Okay.
I apologize. I'm making a terrible check today. Don't be like me. You do a better job. Okay. So, we just have a few more things to cover now. We have one more chest x-ray that we're going to talk about. But before that, I want to talk about upper airway x-rays. Because we have included upper airway, also known as soft tissue neck, as part of this chapter. So, what is upper airway soft tissue neck? We're basically looking at the soft tissue, looking at the throat, the trachea, the larynx, the pharynx, all of that up top here. So, if a patient ever comes into the hospital and says, I think I swallowed a fish bone, and we need to do x-rays for it, we are doing soft tissue neck x-rays. We're doing upper airway x-rays. Does that make sense? So our area of interest is like right here. This section like right here. Like all of this imagery. Okay. Note that the name, even though we're looking at the neck area, we're not interested in the bones, right? This is for the soft tissue of the neck. So, for our soft tissue neck, we are going to be doing AP and we are going to be doing lateral projections. For the AP, if you kind of just take a look at my body here, if you try and x-ray up here, right, there's no airway up above this area, right? This is eyes and above. There's no air up there. Right down here, nose to mouth, a lot of overlapping stuff, right? You've got teeth, you've got jaw, it all kind of crowds it. So really, we're really only going to be seeing mainly from here downwards. This is where our best imaging is going to take place. So we are most interested in this area here for the AP upper airway. Does that make sense? And if you look at the center of this section, it's going to be about right here. This is about T1, T2. Okay, thoracic vertebrae 1, thoracic vertebrae 2. Just a little bit above the jugular notch. So that is going to be our centering for this X-ray. In addition, if you look at this area here, look at how much area this covers. Does this look like 14 by 17 inches worth of anatomy? No. So we are not using our 14 by 17 for this. What do you think we are using?
10 by 12.
Great. We are using our 10 by 12. So instead of 14 by 17 here, we're going to bring this down to 10 by 12. Much smaller collimation. All right. So who would like to be our volunteer this time? Cindy? Back against the board, please. We're doing this AP. So, our goal is to aim somewhere down here. Do you mind if I touch the front of your neck? Okay, so once again, always warn the patient before you touch, especially since the neck and the throat are kind of sensitive areas. Here. So, jugular notch is here, just going to be a little bit above, so right about here. Turn on the laser. Oh, careful, you're going to feel the slide down behind you. All right, great. I think it can come down just a tiny bit. Okay. So, I am centered here to about T1, T2. Something else that you may notice. The top of the light is right here. If you come over around here to the side, and you take a look at where this light is, and you look at your ear, right? So you come over here. This light is actually right underneath her ear. Okay? So that's a way you can quickly check your centering. You expect your light to be right about here, just underneath the opening of the ear, like the external auditory meatus. So it's right under the EAM. Right. So we have our vertical centering. Horizontally, we're going to make sure that we're MSP, straight down the middle of the neck, which we are. Okay. Head positioning, we're just going to lift the chin up slightly so that it's not inside our airway. Right? If I was just straight ahead, my jaw would be covering part of my throat. So I want to lift it up so the jaw does not cover the throat. All right. And now I am going to collimate. I should have showed it as well. I'm sorry. I'm just going to leave it alone for now. All right. So I'm going to collimate it like this. Nice and tight. So I still see light on both sides of my anatomy. So I know that I have all of the neck along with the soft tissue. In this case, I'm working over on this side, so I'm going to use the left marker since it's most convenient for me. And so I've got a little bit of light here. I'm going to squeeze my marker inside the light there. Okay. And so this is pretty much all the positioning we need. Center at T1, T2, collimate, center T1, T2, collimate, center MSP, collimate, and then marker. lift the chin up slightly, make sure the head is nice and straight. And now it is time for breathing. What we want to do for this breathing is we want to see the trachea full of air. If we did our normal breathing instructions, breathe in and hold your breath. When we hold the breath, the trachea is no longer full of air. There's some leftover air, but it's not going to be filled with air. When is the trachea filled with air? What do you guys think?
Breathe out.
When you slowly intake.
So breathe out, yes, but breathe in is even better. So when the patient breathes in, that is when it fills up best with air. So our x-ray is actually going to be done in the middle of the patient breathing in. So for example, you could give instructions like, all right, Sindhu, I'm going to ask you to take a slow, deep breath in. Slow, deep breath. Slow, deep breath, x-ray. Right, as soon as I saw her breathe in, I saw her chest rise, I took my x-ray because she's still breathing in. Now, that might be a little bit too fast. So you could always try 2 breaths, right? All right, Sindhu, I want you to take a slow, deep breath in. Slow, deep breath. Very good. Breathe it out. Breathe it out. Great. Take another slow, deep breath. Slow, deep breath. X-ray. Right? That way you give yourself a little bit more time to prep. And you give the patient a bit more time to prep as well. All right, you can relax. Thank you. Any questions about that? So that is your upper airway. Great. I'm going to hold this so I don't forget.
And it's
Right.
still at 72, right?
Still 72. Okay. So Samantha.
Okay.
All right. So this time I'm going to put this around your side because we are doing a lateral. Hold on to that, please. Thank you. Great. You're going to stand left side against the board. Great. Face me. All right, great. Feet spread apart slightly. Shoulders nice and straight. Okay. Let's see. So we're going to start like this for our lateral soft tissue neck. Now, because we are looking from the side, we are no longer so restricted by all of this stuff up top. So we are actually going to be trying to catch some of the mouth and stuff this time. So our centering is going to be a little bit higher. How high? We are now going to center at around C6. Okay. So earlier we had C7, right, which was vertebral prominence, so C7 somewhere down here. We're going to center at C5, C6, which is somewhere up here instead. Okay. All right, step forward to this one. You okay? Great. All right. And just press your shoulders, look straight ahead if you could. All right. Step back just a little bit. Careful, yep, that's good.
I'm the worst. I think I'm worse than the patients. Am I where we need to be?
We're good for now.
Okay.
We are good for now. All right. So let's put this back to 10 by 12. Okay. And notice, right, our centering is now higher compared to our AP. So we're centered here around C5, C6. Top of the light is going to be closer towards the top of the ear now instead of the bottom of the ear. The patient is doing a nice lateral. And what we're going to do is we're going to have the patient take their hands and bring them behind the back. Okay? Do not have the elbows sticking out like this. Just have them straight behind the back. By doing this, what happens is it pulls the shoulders backwards. Right? Remember, the airway is towards the front. So you're moving these shoulders more out of the way so we can see this a bit more clearly. So one more thing to note, if you look here, right? The airway is towards the front, the spine, the bones are towards the back. Our interest is not in the spine. Our interest is in the soft tissue towards the front. So our centering is going to be more towards the front of the neck. I'm going to slide you. So you see how when I slide her back, right, you see if I slide her backwards, the centering goes towards the front of her neck, right? So that is what I'm trying to do. I'm aiming right here towards the front. I'm going to touch the side of your head. Good. Feels nice and straight. And now I am going to collimate. So you notice that when I collimate, I've cut off the back of the neck here. Right? I don't need the stuff in the back of the neck, right? That spine, those bones. I don't need that. I only need the soft tissue up front here. I have just enough room in the front for me to squeeze my marker in, and I'll also cover this part of the mouth as well. Okay, breathing instructions. What do you guys think?
The same as the AP.
Same as the AP, yes. So, Shamika, could you try giving us the breathing instructions, please?
Okay, Samantha, we're going to get started. I'm going to have you take slow, deep breaths in, let it out. And you're going to take another slow, deep breath in, okay? All right, we're going to get started. Take a slow, deep breath in, let it out. Take another slow, deep breath in. Beep. Relax, breathe.
Very good. So that beat was while she was breathing in. Okay, good. Any questions here? Great, you can relax. Thank you so much. So that covers upper airway. So I did say we had one final position to do for the chest, correct? And that is the chest decubitus. So what do we mean by decubitus?
Patient against the board. Oh, laying down on the side.
No, that.
Yes, the patient is going to be recumbent. And then we are going to place the
Kidney urinary
lateral
bladder.
on her side. And then we're going to put the board
Kidney, urinary
behind her
bladder.
back with a horizontal beam.
To the chest.
So, yes, we are going to be working on the table here. Would anyone like to volunteer to lay down on the table? Okay, so before you do that, I am going to put a sheet. By the way, if I had known ahead of time that I was going to need to do a decubitus X-ray on my patient, should I have this sheet on the table before they ever step foot in the room?
Yes.
Very good. So, lock that in place. Could you please have a seat here? Head over here, please. Lay on your back, head over here. Very good. How is that? Comfortable? So one thing I'm watching for right now is the distance from the table to my tube here.
Does it stop automatically or
To,
the table?
to be honest, I do not know, and I don't feel like testing it out.
Oh, okay. No, I'm just asking.
That is a good question, though. It is good to know your equipment, but I do not know if it has an automatic stopping function. Honestly, even if it did, I would not trust it. Okay. So I've got my patient on the table now, correct? Over here, I have my cassettes. Because this is a chest, which cassette do you think I'm going to use?
14 by 17.
Very good. I'm going to use my 14 by 17. Could you pass me the cassette holder, please? Remember, cassette holder, also known as music stand.
You get it on. I don't need all work around you guys. Yeah, yeah, you guys get your visual.
We'll talk about that. We will talk about that. So so right now, I've got my tube, I have my IR here. What should my SID be?
72?
40?
40?
No, what kind of anatomy is this?
Chest.
So what did I say about all chest anatomy?
72.
72, great. So I have this on cassette, I'm going to pull this out. And what does it say over here? 53. 53 is not 72. So what can I do to improve my SID?
The
Move
table
the
back.
table back.
Great. My tube is as far this way as I can go, right? I can't
Yes.
move it any further. But I can always move the table away from my tube. Okay, so now the table is at its max as well. What does that say?
59.
59. Well, that's closer. Anything else I can do?
Can you take it at an angle?
We don't want to add angles when we don't need to.
Can't move the
Table, music
cassette
stand.
holder?
Great. We can move the patient and the cassette holder further back as well. So in this case, I can take this cassette holder and I can move the cassette further back. And then I'll bring the patient back to match. Don't move here. I'm afraid that cassette's going to fall. Alright, so now what does that say?
62 and a half.
62 and a half. Okay. And that is about the maximum we can reach in this room. Now, some other rooms will give you more ability to slide this way, right? So you would be able to get your full 72. When, in the case of this room, we just go to the maximum possible, as close to 72 as possible. Okay? All right, so now I need a second volunteer, and you will have a very, very important responsibility. Okay, are you ready for this responsibility? Because the Sindhu's life is going to be in your hands.
Okay.
So, we are going to do a lateral chest decubitus. You can do left lateral, you can do right lateral. For the purpose of this demonstration, I am doing a right lateral decubitus. That way, the patient will be in an AP projection. Does that make sense? So, Sindhu, what I'm going to have you do is you're going to turn right side down on the table.
Right side
Right, okay, I get what she's doing. She went
So the
completely
right side down,
upside
this is
down.
the right
Okay.
lateral decubitus.
Okay, yep, yep.
down. Like this.
And now it's on your side, on your side. On your side. Very good, just like that. So, I have her slide as far back as possible so that her hips and her shoulders are touching the IR. Try and bring this right shoulder back a tiny, tiny bit. Good. And then roll onto your side. Perfect. Okay, right arm up, left arm down, hips, shoulders, perfectly sideways. Knees, bend them please, bend your knees. So legs are on top of each other, knees are bent to give her some stability. That way she's less likely to roll. Pillow. Notice the pillow is not under her head. Why? Because her arm is under her head. Instead, this pillow we will put between her knees. Can you lift this left leg up? All right, so hopefully that's a little bit more comfortable. And now, I'm going to have you hold this. So hold this still and try to keep her from falling. Okay? All right. In test out, I will be the one back here helping to hold this for you. So you'll be manipulating the tube. You'll come back over here, move the cassette around, come back here, manipulate the tube. But I'll be standing back here helping to hold it in place, helping to make sure your patient does not fall. Does that make sense? Great. So, this projection is AP, correct? We've done AP projections before. Where do we center for an AP chest?
Yeah.
Great, T7. So let's start with that. T7, how do I find T7? How do I find T7?
Oh,
Armpit.
yeah, yes,
Great.
yes.
So I'm going to slide like this, right, until I find the armpit. Okay. Okay, so armpit looks like it's going to be right here. Do you agree? Does that look like about the armpit?
Yes.
Does that look like about the imaginary nipple line?
Yes.
Okay, that thing's pretty close. Maybe up just a tiny bit more. Okay, I'm happy with that. And then, where else do I want to center?
MSP.
Great, I want to center it to the mid-sagittal plane. So I'm going to drop this down to the MSP. So MSP, between the legs, middle of the neck, or you can ask the patient to point at their xiphoid process, which is this bump at the very bottom of the sternum, the breastbone. So I don't like to palpate for the xiphoid, once again, because this can be a sensitive area. So, Sindhu, can you try and feel down here? Do you feel the xiphoid process right here? You think it's right there? All right, we can move it here. Now, I had the patient palpate this for me, correct? Do I trust patients to palpate for me? No. But I can ask them anyway to see if maybe, right, to see if maybe it helps. Patient says here, honestly, I don't quite believe the patient. So I'm just going to go and trust what I have instead. So you can always try and ask the patient to palpate, but at the end of the day, you should trust your own experience more. Because patients just aren't trained. Now, I found T7 and MSP, correct? Anytime I move my tube, what did I have to do? I have to move the IR. In this case, rather than the wall bucky, I have this. So I'm going to take this and I'm going to move this white line on top of my central ray. Okay, right there. You see that? White line is on top of my central ray. All right. So, Sindhu, from here, I'm going to have, and I just want to point out as well, right, if you take a look at the shoulder here, right? Here's that corner where the neck and the shoulder meet up. You can see the corner right here, right, where the neck and the shoulder meet up.
Oh, yeah, right there.
Okay, so, Sindhu, bring your arm up, please. Left arm up. So meet your other arm. Yep. Great. Sorry, up by your head. That's what I should have said. Yep, up by your head. Oh yes, you don't want your phone to drop. That's very good.
Like this?
Yes, that's perfect. I want you to take a look. Where does it look like her axilla is right now?
Or,
Looks like
yeah.
it's all the way up here now, right?
right.
So that's why I always check my centering while her arm is down. When the arm goes up, the axilla appears to move. But naturally, the bones, the lungs, that's not moving with the axilla, right?
Correct.
So I always check it while she's arms down. Only bring the arms up after I've centered. Okay, I can more easily see my center here as well. Now I can collimate. Right? So I'll go ahead and collimate. I'll go ahead and collimate. Remember, no light past the border of the cassette. You do not want the border of the cassette to light up. Collimate until that light is not there. And then collimate in this way as well. Honestly, I think I could drop this down. All right. So, I'm centered in my cassette this way, and I've collimated nice and tight to the patient's body. Now it is time to mark my image. So, how do I mark this right lateral chest decubitus? Which marker do I use?
Right.
I want to use the right marker. Okay? So, if I have my right marker here, and where's the right side of the body?
Down.
Down. Okay? How
So
am I
it'd
going
be
to mark
left.
this cassette?
This would
In
be,
the light on the cassette.
would it be left? Or
It'll be.
How am I going to find light on the cassette?
It'll be.
How am I going to find light on the
You don't put it up here.
But it's gonna be on the
Well,
opposite
this is the
anatomy.
patient's left side. I can put the right marker on the patient's left side. Yeah, I've got to put the marker somewhere down here, right? Like somewhere all the way down here at the very bottom of this cassette.
Oh.
That's not going to work, is it?
No.
So, which marker are we going to use?
Left.
The left.
That's right. You
This is
mark
not-
the upside.
Ah.
Even though it's a right lateral decubitus, you are going to use your left marker.
Because it's up.
That's right, because it's up. So I have it right there. Okay. Now that I've got all of that done, I do want to make sure that I still shield my patient. So, it's over. I'm just going to take this and drape it over the bottom of the patient here. Right, just barely inside the light field. So I cover the patient, but I am not going to